Absolutely. So in the lower risk MDS in the United States, we had 2 drugs approved in the recent years. We have luspatercept approved originally for patients with ring sideroblasts after erythroid stimulating agents failure. Now it's moved up front based on a study called the COMMAND. So now patients with ring sideroblasts particularly, but all comers can get luspatercept as up front. So this is the first time we have a new standard other than erythroid stimulating agents. Then there is another drug called imetelstat that got approved in the United States recently for patients after erythroid stimulating agents that works in a good way in patients that are highly transfusion dependent. So that's another option. There are several clinical trials going with similar drugs, with anti-inflammatory drugs. In the higher risk, we struggle a little bit more. We've had several phase 3 randomized clinical trials that unfortunately did not show that the outcome was better adding those drugs to hypomethylating agents, but we are awaiting 2 clinical trials. One is called the Verona, where we have venetoclax addition, similar to what we do in AML. Another trial looking at tamibarotene, which is a RAR-alfa agonist. The venetoclax had been used in practice in higher risk MDS, sometimes because of the similarities with AML, but those are exciting studies that we are waiting for, and hopefully we'll have more trials down the road, particularly in the targeted therapy. So for example, subset of MDS patients have IDH mutations. Now we have the IDH inhibitors. In the United States, ivosidenib, which is one IDH1 inhibitor, got approved for MDS. We have another IDH inhibitor called olutasidenib that have data in MDS. So those are some of the promising drugs that will be helpful for a small number of patients.